Wonderful. Thank you all so much for joining us tonight. Emily, thank you for the music. That had been one of my requests is could we start with a little bit of music? But this was Emily Kessler's choice of music, and I don't think it could be any better. We are very excited to have you all here with us tonight. Just a couple of housekeeping things. There is a chat box, so feel free to introduce yourself there, say where you're from, if there's anything specific that you have in mind. There's also a question answer function. You can put your questions in there at any time. We'll be talking about hypertension today. However, Dr. Shah is more than able to answer all sorts of your questions about South Asian heart health. So we're happy to hear about anything during this next hour we'll spend together. So let me introduce Dr. Kevin Shah. He's an assistant professor of medicine at the University of Utah and a heart failure and transplant cardiologist. His research interests include disparities in cardiovascular health and the interaction between COVID-19 and the cardiovascular system. Early in his career, he served in leadership roles, including the AHA, American Heart Association Writing Committee co-chair on key terms and definitions for race and ethnic categorization in cardiovascular clinical research, and on the Heart Failure Society of America Publication and Scientific Statement Committee. Additionally, he has won awards, including House Officer of the Year, the William Parmley Young Author Achievement Award from the Journal of the American College of Cardiology. And most importantly, he was a co-author on the 2018 American Heart Association Scientific Statement, which was on atherosclerotic cardiovascular disease in South Asians in the United States. For those of you who don't know this, this was a seminal paper, and it was the first time that many cardiologists, led in part by Dr. Shah, got together and said, via the American Heart Association to the entire cardiology community, South Asians need specific attention for heart health. It is a real problem, a real burden, and probably needs specific attention. So with that in mind, I'm excited to let him get started, excited for your questions. Dr. Shah, thank you for joining us.
Well, thank you very much for that very kind introduction. Thank you everyone for joining us from wherever you are in the world. We appreciate you all attending these webinars. And today, like was mentioned, I'm actually going to be talking about hypertension. Let me pull up my slides. So, you know, the theme of this webinar is really hopefully a little bit about learning about the speakers as well. And I do want to share a little bit of my story, why this topic is so important to me and why I'm hopeful that today we can actually go through some of the basics of how do we define hypertension or high blood pressure? How do you measure high blood pressure? When do we treat it? How do we treat it? What are the lifestyle considerations, dietary considerations, medications that we reach for to help treat hypertension? And importantly, I do want to spend a little bit of time on special considerations that can really impact our community in terms of considerations of interventions as well as just lifestyle changes. So I do want to help you get to know me a little bit. So we're going to take a little bit of a tour back in time. So this is me back when I was in college. This is a photo from 2005. I was a college student in sunny San Diego, and I was about halfway through my undergraduate education, and I wasn't exactly sure what I wanted to do professionally. Believe it or not, I was flirting with the idea of trying to become a sports announcer because I couldn't really play that well, but I really liked sports and it's something I was interested in. And it was the summer of 2005. I received a phone call from family that my father wasn't doing very well. And again, it was 2005. So the phone call came in on a phone like this. And the call basically said, you know, your dad's being hospitalized. He really is having a tough time breathing. And I said, that's a little unusual. You know, my father's in pretty good health. I'm suspicious what's going on here. So I took the 5 highway and I went up from San Diego to Los Angeles. And when I got to the hospital, I met with a cardiologist, which was concerning. And cardiologist let me know, your father probably had a heart attack. And I said, when? And he said, a little while ago, And there's a good chance that he didn't have a lot of the classic symptoms that you hear about when you think about heart attacks. And I said, there was this episode where there was one day where he felt very unusually tired, pale, fatigued, and there were some friends and family present, but no one ever really thought that he could have had a heart attack. He looked too well. And so unfortunately, as a result of that heart attack, he developed something called heart failure, which is something that I actually specialize in now, which is when your heart becomes weak enough that it really can't provide enough blood flow to the body. And when we have heart failure, there are specific treatments, which include medications. And sometimes, in his case at least, we were actually in the works of discussing listing him for a heart transplant, which is a major ordeal. And while we were beginning the process of doing that, he actually had a cardiac arrest while we were in the hospital. And again, this is almost 16 years ago now, but he was 54. He was way too young and ended up passing away. And as a result of that, we and myself, it was a loss to our family and our community, but it changed my direction in terms of what I would be doing with myself as I grew up. And so I was fortunate to go to medical school and learn with some great colleagues, to do my internal medicine residency in San Diego and learn from some great people. I trained in some amazing places in Los Angeles at UCLA and Cedars-Sinai to learn cardiovascular disease as well as management of patients like my dad who had heart failure and needed a heart transplant. And now I'm at the University of Utah, and not only do I get to practice as a transplant cardiologist, but I also get to help train the next generation of physicians, medical students, residents that are also interested in reducing heart disease worldwide. So it's really come full circle for me. And I wanted to share that as a part of my backstory to help you understand where we're going to go moving forward, really to try to have an impact on our community. And moving forward, the next step is really some of the basics on what is hypertension. We talk about this a lot. You hear high blood pressure, what's your BP, where is this number coming from? Really what we're talking about is the arteries that come off of the heart. What is the pressure exerted within the artery? And what is the potential negative effect of that pressure? We've known for a very long time, really going back to the 1600s, that you can measure blood pressure, and really in the late 1700s that you can use a blood pressure cuff to estimate this. And I'd say in the last 100, 125 years, we've learned that this is clearly a risk factor for problems in the future. When we look across the country, this is data from 2017, just the prevalence of hypertension. Have you ever been told by a doctor, nurse, or any other healthcare professional that you have high blood pressure? And this is obviously a map of the United States of America, and the darker the color, the higher prevalence of individuals stating yes, that they've been told they have hypertension or high blood pressure. So you can see it's affecting the entire country, particularly in some areas more than others. But this is really a nationwide and a global problem. When we talk about cardiovascular disease, there are many modifiable risk factors for developing heart disease. So what we mean by that is things that we can potentially change with our lifestyle, diet, medication that can actually adjust the risk of developing heart disease. And this data here is based on a multinational collaborative study that tries to estimate the disease burden across the world. And they categorize the types of risks as potentially metabolic risks, environmental risks, behavioral risks. And unfortunately, if you look at the very top, in 1990, high blood pressure was considered the highest risk feature, or the most commonly found feature that's modifiable, that's attributable to the development of heart disease. And from 1990 to 2019, that hasn't changed. It still remains really the number one modifiable risk factor for developing heart disease. And the reason why we care about this so much is hypertension or high blood pressure is a problem and a disease in itself, but it can also lead to multiple downstream problems. In other words, it can lead to things like strokes, like vision loss, like heart attacks and heart failure. kidney disease and kidney failure, and other problems. So there are many complications when someone has hypertension, particularly if it goes untreated. And when we talk about our community in specific, this really matters because this has been studied specifically amongst the South Asian community. These are data from, this is a multi-ethnic cohort study where they really followed individuals with high blood pressure and they saw how they did over time. This is data from London. It was published just over 5 years ago. And importantly, what we're looking at is Europeans compared to South Asians, and we're looking at different measurements of blood pressure. So systolic blood pressure, the first number, diastolic blood pressure, the second number, mean arterial pressure, it's really the average of those two. And the OR or odds ratio is the likelihood of that number being associated with, in this case, a stroke. And unfortunately, the odds ratio for a lot of these blood pressure parameters within South Asians was highly associated with the development of a stroke and higher than it was in the Europeans or the Europeans in this study. In other words, if you're of South Asian ancestry and you have high blood pressure, the risk of developing a stroke is what you can see here, and it's higher than if you're not South Asian. When we talk about high blood pressure and just cardiovascular risk factors, I mentioned high blood pressure is it's really the leading cause of death and disability adjusted life years worldwide. In America, it accounts for more heart disease deaths than any other modifiable risk factor, really second to smoking. And this table here, we're looking at risk factors common in patients with high blood pressure. When we think about risk factors, oftentimes some of them are modifiable and some of them are relatively fixed. Modifiable risk factors we can potentially do something about. This includes not smoking, managing diabetes, managing cholesterol, obesity, physical inactivity, and diet. These are commonly found in individuals who have high blood pressure. And these are all areas that we can all work on to try to lower the risk of really developing heart disease. So the risk factors for hypertension. Unfortunately, some of these are things we can't change. So there can be a genetic predisposition to having high blood pressure or hypertension. The amount of salt that goes in one's body, whether it's added on top of food or within processed foods, consuming more salt can raise your blood pressure. Unfortunately, the diet and the foods that we choose to eat can potentially raise one's blood pressure too. We're going to talk a little bit about the diets that have been shown to potentially lower blood pressure. Alcohol consumption, so over consumption of alcohol can also raise one's blood pressure. And unfortunately, obesity. So being overweight or being obese has an impact on your blood pressure. And conversely, losing weight can also lower your blood pressure. So how to measure blood pressure is actually very important. And the reason why it's important is because there are errors that are somewhat common when we try to measure blood pressure. So if we're not aware of what those errors are, it's hard to actually avoid them. And we make decisions based on how we're going to help people based on the blood pressure readings. So when one's blood pressure is measured, whether it's at home or in the clinic, really you should be relaxing. You should be sitting for 5 minutes. You want to avoid caffeine, exercise, and hopefully smoking, period. You want to empty your bladder, and you really shouldn't be speaking or talking when the blood pressure cuff is measuring your blood pressure. You should use a cuff that encircles an appropriate amount or 80% of your arm. So too small or too big of a blood pressure cuff can affect the readings and can affect how we use that information. On the first visit, if you're seeing a doctor for the first time, you should record your blood pressure in both arms, and it should be repeated by a couple of minutes. And you really want to use averages of blood pressure readings. And we're going to talk about measuring in the clinic. We're going to talk about measuring at home. And sometimes there's a discrepancy or a difference between those two blood pressures. But importantly, when we talk about high blood pressure, this is a problem that usually does not have symptoms. And when a problem does not have symptoms, we have to screen for it, meaning we have to test or look for the problem in people who feel fine. So the US Preventative Service Task Force recommends we start screening or looking for high blood pressure at age 18, and we should check every year to make sure someone's not developing high blood pressure over time. And if you have risk factors for heart disease or your blood pressure has ever been elevated, then you should have it checked twice a year. This is probably one of the more important slides that I can leave you with today. This is back in 2017 when the hypertension or high blood pressure guidelines were redone and re-released. This is the new categorizations for blood pressure. So each column, we're looking at blood pressure category, systolic or the first number, diastolic, the second number. And as we go down by the rows, we're looking at normal blood pressure, which as you can see is less than 120 and less than 80, elevated, so 120 to 129 and less than 80. Stage 1, where you actually say someone has hypertension or high blood pressure is greater than 130 or greater than 80 for the second number. And then there's also stage 2, which is greater than 140 or greater than 90. The reason why these categories were made the way they were is there really is a stepwise increase in the risk for heart disease and strokes as you go up in terms of severity. So if you're stage 1 hypertension, you actually have twice the risk of a heart attack compared to the general population. And like I mentioned, when someone's making this diagnosis, usually you want to have validated equipment, and you want to make measurements of blood pressure at least on 2 separate occasions to make sure you're not having one that's unusually high. There are these other subtypes of hypertension that we're learning more and more about over time. So you can have your blood pressure measured in the clinic, as you can see on the left, or you can have it measured at home, which is ambulatory blood pressure. And the way blood pressure can be measured at home is usually with some sort of a home blood pressure cuff. The challenge here is there are some individuals whose, if their blood pressure in the clinic is high and their blood pressure at home is high, it's called sustained hypertension, or we know it's high blood pressure and we treat it as such. Conversely, if it's normal in both settings, your blood pressure is normal. There are groups of people that have what is called white coat hypertension, meaning when you see someone in a white coat potentially or going to see the doctor, your blood pressure is high in the clinic, but when it's measured at home, it's actually normal. And this is still something that's not completely normal. And there is a percentage of people that can have white coat hypertension that still progresses to high blood pressure or hypertension. Conversely, there are individuals that have high blood pressure at home, but when they go to the clinic, it's actually normal or masked hypertension. So this really gives us more insight into the fact that blood pressure measurements in the clinic represent a moment in time, and really what happens at home matters too. So having a blood pressure cuff that's accurate and keeping routine measurements is very important when you're working with your doctor to come up with a good treatment plan. So when we talk about what can actually be done, first and foremost is always lifestyle recommendations. Really all stages of hypertension, even elevated blood pressure, but not technically hypertension, these are steps that are recommended. So these include things like weight reduction, so keeping your body mass index within normal body weight. And truthfully, within the South Asian community, this can be an area of discussion, I would say, because there are many with a normal body weight but still can have high amounts of fat in their body. So I would say losing weight is a good thing, particularly in our community, and this is associated with lowering your blood pressure. Something called the DASH diet, which I'll tell you a little bit more about soon. Lowering your salt intake, so less salt added on your food, less salt in your food is going to lower your blood pressure. Being physically active, so trying to aim for at least 90 minutes to 150 minutes of aerobic exercise. So going for a walk, pushing yourself on your walks will lower your blood pressure. Alcohol consumption in moderation. So no more than 2 drinks a day for men or 1 drink per day for women. excessive consumption of alcohol or too much alcohol will raise your blood pressure. Taking less of it in your body can lower your blood pressure. This DASH diet, this is really a diet that was formed and studied to stop hypertension. And so in its simplest forms, it's trying to eat a high amount of whole grains, vegetables, and lean protein, legumes and nuts, while trying to avoid as much fats and sweets. And making this diet compatible with a traditional South Asian diet is actually, frankly, not that easy. But it's important to keep in mind the sort of the basis of the diet is to try to consume more fruits, vegetables, and whole grains, and less fats and sweets. And when this diet was actually studied, it was proven to lower blood pressure. And that's why it's really made its way into our guidelines if you have high blood pressure. So this is really an algorithm for how most of us who treat patients with high blood pressure, how we think about our patients. So if you're being screened or you're being evaluated for high blood pressure, if you go to the far left and you truly have normal blood pressure, then all is recommended is good lifestyle habits. Things that we talked about already, like staying physically active, moderate alcohol consumption, things along those lines. If you have elevated blood pressure, but technically not hypertension yet or stage 1 hypertension, that's when these non-medical treatments are reinforced. So everything that we talked about from a lifestyle standpoint to keep your blood pressure controlled. If you have stage 1 hypertension, so this is 130 to 139 over 80 to 89, here, individuals that, and this was a big change back in 2017, people that have established heart disease, so if you've had a heart attack, you've had a stroke, things along those lines, then you're considered high enough risk where you start medical treatment. And we'll get into what medical treatment is. The other reason you would start medications if you're at stage 1 hypertension or high blood pressure is if you're high risk for developing heart disease in the future. And we'll talk about exactly how we calculate that. And then lastly, on the far right is stage 2 hypertension. So this is starting off at a high point and a really high risk point in patients that we meet that are starting off at stage 2 hypertension. We recommend those same lifestyle changes. Medications start right away, and oftentimes patients will need more than one medication to control blood pressure. As I mentioned, if you have stage 1 hypertension, one of the calculators that we use to try our best to estimate your future risk for heart disease is something called the ASCVD risk estimator. This is a risk estimator for the likelihood that you may develop heart disease within the next 10 years. And these are the components that go into a calculator when we're trying to estimate risk. It includes things like your age, your sex. I'll point your attention on the top right. Race, it's really limited in terms of how much we can use the information here. So you're either categorized as white, African American, or other, which other is obviously a very broad category of people. Really, you get points, particularly if you're African American here. And honestly, there's a lot of unknown data when we talk about how much being South Asian should impact this ASVCD risk score. Other things, cholesterol, if you have diabetes, if you smoked, if you're on medications, as you can see on the bottom, statin or aspirin. So all of these go into a calculator. And if you're considered higher risk for developing heart disease and you have hypertension, then you get started on treatment to try to lower the risk. When we talk about treating hypertension, the first medication that we reach for, truthfully, there's no specific one medication that is recommended. There's actually a slew of medications. These include things like water pills, like chlorthalidone, calcium channel blockers like amlodipine, lisinopril or losartan, which are called ACE inhibitors or ARBs. Between selecting these medications, oftentimes there's another reason to be on one of these medications. Particularly in our community, there's a high prevalence of diabetes. So a lot of patients will end up on things like lisinopril because it's not only recommended for high blood pressure, but it's also recommended for diabetes. So these are the drugs that you'll often see. Which ones tend to be tailored based on other medical issues that it could also help. this issue of yoga and meditation, it comes up a lot. And there's a lot of people within our community that are regular practicers. And so they've both been studied in scientific form to try to see what is the impact on lowering blood pressure. And when yoga was studied, there has been some modest but significant lowering in blood pressure. And these are truthfully hard studies to do when you have a group of people that do yoga versus don't do yoga and you measure their blood pressures over time. Similarly, meditation, there's some data to show a particular type of meditation called transcendental meditation, which is a mantra form of meditation, has the potential to reduce your blood pressure as well. So this question comes up a lot about, well, can I do yoga to lower my blood pressure? Or can I do meditation to lower my blood pressure? And I think these are fantastic, fantastic additions to the things that we talked about earlier in terms of lifestyle changes and in terms of medications if you need to be on a medication. So this is important recent data, I would say, published very recently. If you're not familiar with the study called the Masala study, this is a cohort based in the United States of South Asians that reside here that has really done a fantastic job. It's essentially a modern Framingham study of South Asians in the United States. Many are in California, many are in Illinois, and they're people without established heart disease that they're following over time and trying to figure out what will predict the development of heart disease within our community. And a number of extremely impactful publications have come from this study or from this cohort. And this is very recent data that was particularly looking at hypertension within the Masala cohort and what percentage of patients should be on medication but are actually not on medication. This study was looking at a few different things, but I highlight this data because on the bottom, we're looking at the old blood pressure guidelines, which we call the JNC7. On the top, we're looking at the most recent guidelines. And in this study, they included data from Masala and another large important cohort called the MESA study. And when you look at South Asians, whites, blacks, Hispanics, Chinese, all these different colors across here, or the percentage of people that had untreated high blood pressure that qualified for medications. So amongst South Asians, you see this yellow bar of 9%, this light blue bar of 8%. That represents 17% of people that are in the study that clearly qualify for medications and are not actually on medications. And that number has gone up since the guidelines changed because the guidelines have become more strict. And so as a result, there's more patients that could and should be on medications for high blood pressure, but they're actually not. So this is directly impacting our community because these are areas for improvement when we talk about who should be on a medication. And as many of you may or may not know, there are a lot of clinics that are really popping up across the country that are focusing on our community, and for good reason. The heart disease issue is growing. It's growing within my generation. It clearly exists in the generation above, and multiple centers and sites are developing clinics that are really focused on the high-risk nature of our community and how to best not just help the community, but also study it within the community. And I can tell you, at least for me, a professional goal of mine is to develop a clinic like this myself because of the story that I shared earlier, but also because it can really help give back to our community. So to wrap up, so high blood pressure, it is really one of the most easily recognizable if you screen for it appropriately, and it's a major cause of cardiovascular disease across the world. Unfortunately, it usually does not have many symptoms, so you have to do regular screening and you have to do accurate screening to catch high blood pressure, to implement lifestyle changes as well as medications to try to lower the risk. Within our community, we're really high risk for heart disease, for metabolic disease, for diabetes. We need more data specifically within the South Asian community. We do not have specific data about blood pressure goals for us, BMI goals specifically for us, A1C goals specifically for us. But rest assured, if the studies would be done, I suspect lower the goals within our community, we'd probably do better from a population health standpoint. I talked about lifestyle modifications. These are very important additions to everything that we mentioned. So I do recommend yoga. I do recommend meditation for people that are interested in it. And I would say most importantly, we really need to spread the word. We need to be comfortable discussing these issues: high blood pressure, diabetes, obesity, what we can do to help each other, to recognize that they're common, that they're treatable, that they're manageable, and it's okay to talk about them within the community. I just want to say some thank yous to the American Heart Association, Dr. Bott, some mentors and sponsors of mine, Dr. Watson, Dr. Volgman, my team here at the University of Utah. I do want to give a shout out to the Masala team, because honestly, they're doing some of the best work in this space. Everybody on social media that's really been promoting this issue and this cause, and then family and friends, if you're able to join today. These are pictures of me and our two daughters. And I do thank you for your attention. And like I said, here's my contact info if you want to reach out to me. Let's work together to improve the health of our community.
Dr. Shah, thank you so much. Thank you for sharing your story. Thank you for making this your career, because you have made such changes just in the development of this field over the past several years that we're really proud of that, and really trying to follow in your footsteps, because you kind of set forth what the guidelines should be and what we don't know, what we need to know now. And I think when you do start that program locally, it's going to be a phenomenal one. So we're excited for that. You have the audience thinking a lot, and we have a lot of questions, so I'm just going to jump right in. Let's just start with the reading of the blood pressure, the systolic or the top number, the diastolic, the bottom number. In South Asians, are they both elevated? Is one more than another? And when people are looking at the numbers, is one more important to you than the other, or do you need them both to go down?
That's a really good question. The most information or data that we have is on the first number, the systolic blood pressure. A lot of the earlier data was actually only focused on that. There are cases of people that have what's called isolated diastolic hypertension. So the second number is high, but the first number is not as high. And we don't really have the large data that we have based on as compared to the first number for the second number. So within the South Asian community, unfortunately, we don't have specific information between the two. Most of us care about both numbers equally, and most of us tend to react strongly to the first number, but both of them matter. And if you look back at that slide that showed the different stages of hypertension, many of them say this or that, this or that. And the reason why that's there is because acknowledging that the second number does carry risk too.
So as I'm going to ask you the next question, actually, Kevin, would you mind pulling up that slide again so that people can spend a little time looking at it as we talk about these questions, and then maybe even grab their phones or get a screenshot for themselves to hold on to that. So while you're pulling that up, Megan Bhatti is asking, how does the cardiovascular hypertension risk vary among South Asians who are in South Asia versus those living in the US? And is there variations within the immigrant populations or over the generations? Do we know any of that yet? India versus here, and different generations in the US?
Yeah, that's a really good question. And the study that I mentioned, this Masala study, I would encourage everyone to at least look it up and see some of the publications that have been generated from it. A lot of individuals that, particularly my parents' generation, that emigrated here as compared to us. The challenge when you're trying to compare across, frankly, is we don't have a lot of refined data based on people in India now. And unfortunately, when people have come here, the westernization and the negatives that can potentially come with that make it really hard to actually tease out what's impacting the community here. So there's a high prevalence of heart disease within India. There's a very high prevalence of heart disease within here. And there's something about coming here that unfortunately, I think many of us have become more sedentary. Many of us have potentially taken on dietary changes that aren't necessarily beneficial. And I don't think necessarily the westernization of our life has actually helped from a cardiovascular health standpoint.
That's a great point. That's a great point. When looking at these blood pressure categories, since you have this up, a few specific thoughts. So one is if patients are checking their blood pressure at home, is there a specific time of day or multiple times per day? And is there a specific relationship to their medication if they're on antihypertensives that you'd like people to be checking these blood pressures?
That's a really good question. So there is there is a typical pattern with blood pressure in general. So most people, your blood pressure starts a little higher in the mornings and it comes down over time. And when we recommend patients check their blood pressure at home, I usually recommend it's checked at least twice per day and sort of in the same fashion. So like we talked about, sitting, quiet, resting for a few minutes beforehand, not speaking when it's measured, and logging both of those numbers, because we use really the averages over time. So we try not to make large decisions based on one number. We try to make decisions based on numbers over time. And if you start a blood pressure medication, the same principles apply. If you're measuring your blood pressure multiple times at home and you're on a new medication, usually we try to see you back in a clinic 2 to 4 weeks. And between what we see in the clinic and what we see at home, we use that to either increase the dose or even add a second agent to try to lower your blood pressure again. The goal is to try to get you at least down to elevated by it, but ideally back to normal if you can tolerate the medications.
So as you say that, for the people out there who are trying to be really specific about green versus yellow and orange on this graph, if you're checking your blood pressure at home and you're finding yourself in the yellow range, let's start there. What should you do?
Yeah, if you find yourself in the yellow range, so you learned you have elevated blood pressure, this is where the lifestyle changes do matter and can have a big impact, right? We showed on that one table, some of these interventions, 4, 5, 6 millimeters of mercury. That's being physically active, changing your diet. We talked about yoga, meditation. Those are the types of things that can push you from elevated down to normal. And frankly, beyond just blood pressure, they clearly have an important impact on cardiovascular health. So if you're elevated and you're trying to get down to normal, those lifestyle changes can really bring you down.
Fantastic. And how long, Kevin, in your practice do you give them to make those lifestyle changes? How long until you say, boy, this isn't really happening?
Yeah,
What's a
that's
good faith
actually a good
effort?
question. I think everyone's threshold is a little different, but I would say at least a few months.
Great.
Because this is the same with cholesterol too, right? The first and foremost bedrock of managing high cholesterol is really always lifestyle changes. And there are some people that really change what they do from a day-to-day standpoint. And we see very impressive changes in their lipid panels. And sometimes you can forego starting a medication like a statin if the lifestyle changes can bring things down. For high blood pressure, it's the same principle. A few months of trying these lifestyle changes, keep measuring the blood pressure at home, come back and see someone in the clinic. And again, the goal would be to try to normalize your blood pressure.
That's perfect. And I think we do, I do something similar here. I used to tell people 6 months, but that feels very far away and doesn't really necessarily get you to get out there and do things. So I do now say 3 months. And if things are going kind of well, we push on and we look at 6 months. And if in 3 months we've made no changes, we have a real conversation about what's going on and what can we do. Good. What if you have somebody who has diabetes? What if you have somebody who has a very strong family history of cardiovascular disease? And then last, what if you're somebody who actually does have known coronary artery disease? Do you treat those groups differently in terms of blood pressure goals? So diabetes, family history, and then if you have disease.
Absolutely. So if you have established heart disease, if you have known coronary artery disease, and once you're at stage 1 hypertension, then the goal is to bring your blood pressure down, because it will have a major impact on reducing the risk of further coronary artery disease. Diabetes, the same thing, same principle applies. If you have established diabetes, you often are already started on a medication like lisinopril or an ACE inhibitor. And so as a result, you're going to bring your blood pressure down. And the family history, I think that's a really good question. We talked about these risk calculators that we use, and the family history doesn't have a great place in that risk calculator, but I think it's an important contributor. So when someone has elevated blood pressure and a strong family history, I do think it's a little bit of what we call shared decision making. In other words, talking with our patients about the lifetime risk potentially of having elevated blood pressure progress to hypertension in the setting of their family history, and working with them to either come up with a lifestyle program or start medications early.
Great. Just to clarify for some of the audience, If your blood pressure has come to normal range, do you still need to check it regularly? And again, can you just tell us times of day that you like to check blood pressure?
Yeah. So it should be screened formally once per year, once you're 18 years old and up. If you're already an adult, I would say so twice per day is the minimum, and I would keep it at a set time per day. So 9 a.m., 5 p.m., 9 a.m., 5 p.m., and jot it down. And I missed, was there an
And
addition?
if it ends up being in the normal range, do you still have to check twice a day once you get on your antihypertensive, or can you lean back, or do you ask your cardiologist what they recommend?
Yeah, I mean, for all of these things, I would work with your physician specifically on coming up with a plan. So you want to plan for starting the medication, you want to plan for monitoring once you're on the medication, and then how do you adjust from there? And every physician will have a different approach a little bit in terms of how often they're going to check in with you, watching your blood pressure over time, and frankly, working with you to actually increase the dose of the medication if it's not reaching your goal. So I
Wonderful.
think it will be tailored a little bit to you and your situation.
That's great. And I think the point that Dr. Shah makes is good and answers some of the questions out there, which is, so when you take your blood pressure medications, the majority of us recommend taking them in the evening or before bedtime. Some medications, however, will be more than once a day. And so you'll end up taking it multiple times during the day. Sometimes one blood pressure medication isn't enough. So we still try to push those lifestyle changes to try and stay on as few blood pressure medications as possible. But as you're making those changes, you may be on more than one blood pressure medicine, and that's okay, especially if your doctor has said that that's what you need. People don't automatically prescribe one over the other first, especially in South Asians. And maybe Dr. Shah, you can comment if you have a preference, but many physicians will choose what they're more comfortable with, or they'll choose it based on if you have diabetes, they may give you an ACE inhibitor. If your heart rate needs control or you have atrial fibrillation, you may get a beta blocker. So oftentimes they're thinking about the whole picture of you and then picking a medication. And it's always good to ask your physician and advocate for yourself. Doc, why are you picking this one first? It is okay to ask people. Dr. Shah, other thoughts about medication timing or number or type of medication?
No, I completely agree with you. A lot of times physicians will choose medications, frankly, because they're most comfortable with them, right? And medications change over time. Newer formulations come out, new classes even come out. And I think it's important to ask why this medication specifically for me. A lot of times it's usually because of another medical issue and you're trying to really tackle both issues at the same time. And it's important to have the conversation because honestly, we want our patients to know why we're doing things. We want our patients to know the specific reasons for why we're recommending something. And I think sort of owning that a little bit and having that extra information helps us as doctors because I have found patients that ask a lot of these questions, they seem to be not just more invested in their health, but the curiosity is a good thing. We welcome the curiosity. We don't always know the answer, but we welcome the curiosity.
Wonderful. Let's talk about women in heart disease for a minute. South Asian women, do they need to have a lower blood pressure target than South Asian men? Do we know? And then does it matter if they're premenopausal or postmenopausal? There's an anonymous attendee who says recent studies showed that women start developing increased risk after 110 millimeters of mercury.
Yes.
110 is your top number instead of 120.
Yeah, that's a great observation. I mean, that's very recently published data, I think just maybe 1 week ago, of recognizing this discrepancy between sexes, between men, between women, and these guidelines, the ones that we had up earlier, that's really for the whole community. My hope and my goal is these studies that are coming out, you're seeing sex-specific findings there's an association with lower blood pressure, less than 110, with women with doing better long term. We don't have studies yet to show that if we specifically ask a group of women to try to get their blood pressure lower than 110, that they will do better than a group of women that we don't ask them to do that. But we're learning more and more about these differences between sexes. And honestly, we're learning more and more about these differences between races, ethnicities, and biologic ancestry. So from my perspective, I don't think we have specific information yet to counsel a South Asian woman versus a South Asian man, not yet at least.
There we go. So Dr. Shah, we are very excited to work together with you to be able to make that study happen. I suspect we have a lot of volunteers already in the audience who would be happy to see whether or not women need a lower blood pressure range. So let's turn a little bit, if you don't mind, to thinking about fasting, the keto diet in South Asians and cardiovascular disease. Any data on intermittent fasting or keto in our population and whether, or in general, that you would share with us for now?
Yeah, intermittent fasting is fascinating, right? Because it's gotten so much attention, I would say, in the last few years as really a fantastic weight loss strategy, first and foremost. And it tends to be effective. So intermittent fasting, there's sort of many different ways to do it, but a lot of people basically choose not to eat any food for a large chunk of their day. I've seen kind of most commonly early dinners, no food after that, skip breakfast, which some people do anyways, and then eating sort of a late breakfast or early lunch. So limiting the amount of time that you're actually consuming food. There's good data to show you can lose weight that way. And when you lose weight, blood pressure tends to come down. So I personally don't have my own experience with intermittent fasting, but I've seen a lot of patients that have actually lost a lot of weight. And like a lot of things, I think some of it comes down to what your sort of pattern of eating was even before you started intermittent fasting.
Great. And if we're thinking about LDL, there is a question about LDL less than 70 versus less than 100. You talked a little bit about goals in blood pressure and goals in LDL. Would you let us know what your thoughts are on that as well?
We're learning more and more in general, the lower your LDL, the better. Frankly, across and how you get there is sort of a separate conversation. If you have known heart disease or you've had a heart attack, really the lower you can go, the better. Less than 70 is a good place. The general recommendations, if you're at risk for coronary artery disease, but you're not, if you don't have established or you haven't had an actual heart attack, the thresholds, like you mentioned, usually 100 or less than 110 of the LDL. Again, for the South Asian community, my personal practice and my personal preference is to try to get it, I think lower is better. And I don't think we have specific data to say this is the threshold for this community. We don't have that data yet.
Okay. And while we're on that topic, this comes up every week, so I just ask it of everybody who visits with us. There is this lipoprotein little a that is not usually in the cholesterol panel that your average primary care in America will ask for.
Yes.
There is some talk of it being more important in South Asians. Would you recommend that when we go to the doctor and we get a cholesterol panel, we ask for the lipoprotein little a? And then if we get it, is there a cutoff or something that's important for us to know?
So LP little a or lipoprotein little a, the reason why this comes up a lot is that this is a type of cholesterol that we know within our community, we tend to see higher levels. And it's been associated really with a genetic predisposition for coronary artery disease. The challenge up until recently has been if you identify someone with high LP little a and the rest of their cholesterol is fine, we haven't really had much treatments to bring this down. There are studies now specifically targeting that molecule to try to bring it down that are called outcome studies. In other words, if you bring that down, can you lower the risk of heart attacks and strokes in people? And those studies are ongoing now, specifically within our community. I think it's an important marker to at least check, particularly if you do have this family history of heart disease. I have my LP little a checked. First time I had my lipid panel checked, which was shortly after everything happened with my father a long time ago. My LP little a was high, everything else was fine. As you can imagine, between the family history and the LP little a, I felt very comfortable having a conversation about medications for me. So if you are South Asian, I think it's probably in the past people were reluctant to check it because nobody knew what to do with the information. But like a lot of things, I would say stay tuned because there are companies that are working on treatments focused on that specific risk factor.
Great. Thank you for telling us that. If you don't mind sharing one more thing again to direct our last set of questions to the slide that you had about the different things that we can do and how much it lowers blood pressure.
Yeah, I
Some
can
people
pull.
are asking if you can put that back up so that they can take a picture with their phone or do a screenshot just to
Yes,
get a
indeed.
sense of lifestyle change. And while we're doing that, do you have a number of steps per day that you'd like people to achieve?
10,000 is nice if you can do it.
Okay, there we go.
10,000 is nice.
10,000 steps a day is the answer to that question.
Yeah.
I'm going to have to recheck my watch and phone and see whether I got to that today. I may need to go walk the dog in circles a couple times. Good. How about coffee? Is it bad for us? Is it raising our blood pressure? Is it good? How much can we have? Does it affect cardiovascular health otherwise? It's not mentioned on this form.
It's a very good question. You know, coffee is one of these uh, things that many of us consume, and honestly, every few years you'll find a new study that shows associations with very positive things, and you'll find associations with very negative things. Personally, I think there's more data to support coffee from a heart disease risk standpoint, but like a lot of things in life, if you already consume coffee, I would say in moderate amounts per day is okay. It will raise your blood pressure slightly, but there are clearly other impacts that it has on the cardiovascular system that when larger studies are done, and essentially they ask people how much coffee you drink and they try to compare across groups of people, people that tend to drink a little bit more coffee, we're finding more science that points towards better health outcomes. So I wouldn't recommend someone start drinking coffee, but if you drink coffee and it's a part of your lifestyle, I think that's okay.
Great. Dr. Sharma is asking, are South Asians especially salt sensitive? Is that something that everybody should really keep an eye on?
It's a good question. I can't say I've seen any specific information on salt sensitivity within our community. We're clearly affected by high blood pressure, and clearly a lot of our diet tends to have salty foods, but I haven't seen anything specifically about salt sensitivity within our community.
Great. And last two things. Actually, no, we have a little bit of time. So blood pressure monitors, do you have favorites? And if you don't want to say companies per se, we don't really do that with the American Heart Association, although you're welcome to mention them.
Yeah.
Do you have just types, wrist versus arm? Are they as good at home as they are in the hospital? Just some thoughts about measuring blood pressure.
That's a really good question too. There are a lot of different types. Generally speaking, I don't have a specific recommendation other than if someone gets one, I think it's a really good idea to bring it to the doctor's office that you're going to be seeing regularly, because what you really want to do is have them measure it in the clinic, you measure it with your home device, and have those numbers be pretty close to each other, because we're going to use that information from home, honestly, sometimes just as much, if not more, than the information in the clinic. So if for some reason, whether it's on the wrist or the arm, if there's a large discrepancy between the clinic blood pressure and the home blood pressure, if we make decisions based on that home blood pressure, we can steer you the wrong direction. So I personally don't have recommendations. I'm not sure if you do, but I think it's important to at least make sure it correlates.
Yeah, no, I would agree completely. I think when you get that new blood pressure cuff, go on into your primary care cardiologist's office and just have them do a quick check. You don't have to be there to see the doctor. You can actually call the office and say, hey, I want to come in for a blood pressure check. Can we check my blood pressure and my machine against your machine? They'll actually be really excited that you have that blood pressure cuff at home and you're going to use it. So please do that. And if the majority of you don't own a blood pressure cuff at home, I actually strongly recommend that you get that one. They come in all different shapes, sizes, and price points, but really important to be able to check at home. And so I would strongly recommend that if you are of South Asian descent, you should probably own one in the household, even if you feel like you're younger and you're probably okay. If you're not regularly checking, I suggest you check. If you go to the doctor and they say, oh, well, you must be nervous, you must have run into our office, that is why your blood pressure is high. That may be true, but remember that also means that anytime you're stressed, your blood pressure is that high. And so then think about how many times in a day any of us may be stressed. Those are how many times your blood pressure is out of range. And so even a high reading one time in the office, which we used to say, don't worry, it's probably because you're here. It's white coat hypertension. That's not really a thing. That's not great for you to have, and that shouldn't be our response. So please do go get a cuff and try it at home. So Dr. Shah, thinking about people who are now looking at social determinants and saying, are there social determinants that cause these disparities? You did cover some cultural issues. So a little bit about how we eat, salt in our diet, a lack of physical inactivity in our community that we're trying to combat. But are there other social determinants, Megan Patti is asking, that we're also missing or should be thinking about?
I think one thing that's just important within our community, I sort of touched on it in the end, is this idea of normalizing these conversations. In other words, I don't think there should be any shame. I don't think there should be any shame if someone has diabetes or if someone has high blood pressure and they really need help with it. The idea of normalizing medical problems and normalizing conversations about heart disease is really important because frankly, if someone doesn't feel comfortable talking to their community about it, to their family about it, to their peers about it, I think a lot of time people won't seek care. And that's one thing I've learned in my few short years as an attending. It's you want people to feel comfortable talking about their medical problems with you and their loved ones. And folks, when people are more comfortable talking about these issues, I really think we can actually help a community instead of trying to keep things either quiet or under wraps or within the family. I think it's okay to talk about these things. And my hope is our generation of physicians, we really normalize these conversations, because if we do, I think people become a lot more comfortable seeking medical care.
Absolutely. Well, thank you so much for being with us tonight, Dr. Shah. I think we could go on for another hour with lots of questions, discussion, but we'll definitely have you back again. Thank you to the audience for joining us again today. We'll be back the first Tuesday of next month as well, and we've lined up speakers through all the way through the rest of 2021. As I may have mentioned to some of you on past calls, the American Heart Association nationally is now interested in picking up our Little Boston webinar and making it a national effort, not just the webinar in education, but thinking about dollars for research, focusing on South Asian patients, and helping people like Dr. Shah and others set up local centers throughout the country. We also have other groups that are trying to replicate these kind of programs. I know Dr. Mehta is here from ICC, and so we're very excited to work with your groups if you're working on similar educational programs for the community. This was just such a wonderful day, Dr. Shah, and so great to have you. I'm going to end with reading a panelist comment or an audience comment because I think it's perfect. It says, it's from Maya Mystery, and it says, "Thank you, Dr. Shah. Your career is a fine tribute to your dad." So thank you so much for being here today. Thank you to the audience, and we will see you all again in 1 month's time. Be healthy, be safe, and go out there and get a blood pressure cuff.
Thanks, everyone.